Welcome back, and we're into pressure support tutorial 2 now. We've seen how the breath is triggered on a modern ventilator. Now we're going to look at a critical part of the breath, that is the initiation, how the ventilator sends flow into the patient's lungs and how that can be controlled by a good and well-trained bedside practitioner. Tutorial 9. Pressure support ventilation. Part 2. Control of inspiration. In the first tutorial on pressure support, we looked at the concept of assisted spontaneous breathing and the indications for using modes that assist the spontaneous breath. And we're particularly talking about pressure support ventilation, by far the most widely used mode of assisted spontaneous breathing. We looked at triggering of pressure support, and then we evaluated the flow and pressure triggers in pressure support, looking at the strengths and weaknesses of each, and then looked at the twin problems of under-triggering and over-triggering. In this tutorial, we will look at the initial flow of gas after the ventilator has been triggered in pressure-limited breaths, and then we look at one specific setting, and that's the inspiratory rise time, or the slope of the inspiratory flow curve. And when we've introduced the concept of the rise time, I'm going to look at dyssynchrony at that very, very early stage of the breath. Subsequently, we're going to see what happens after the initial flow of gas has completed and the patient is still inspiring and gas is still flowing and we haven't reached expiration. And I call this midrange flow. And I'm going to talk a little bit about dyssynchrony during midrange flow in this tutorial. Setting the initial flow. It's really important to understand that pressure support is a mode that controls flow in a big way. It's really quite a sophisticated mode of ventilation. And the key thing on inspiration is to make sure that you match patient demand with flow. So as the patient takes an inspiratory effort, the flow is generated, it matches inspiration neatly, like in this picture here. The bigger the inspiration the patient takes, the bigger the inspiratory effort, the greater the flow, and they should just match up neatly. In this situation, there's a slight delay in matching demand from flow. So the patient is demanding that the ventilator generate a flow, and it registers as negative pressure within the breathing system, but the flow is too slow coming to the patient. And this will result in demand flow dyssynchrony. We've seen this with scooping and volume assist control. We've seen it in pressure support before. And this is, the patient is taking a breath, but the flow is just too slow being delivered. Another anomaly is that the patient may generate a breath, but the flow is just too big with respect to the patient's effort. And as a consequence of this, the ventilator pressure cycles very, very quickly. So the patient is inspiring, but the flow is too fast and over-pressurizing the airway. How do you do tight adjustments on inspiratory flow to match the patient's demand so that everything looks well and with a lovely flat top pressure waveform? Well, the pressure ramp can be adjusted to control the initial flow rate. Essentially, buffers are added to the sides of the breath to slow down initial flow or increase initial flow to give you greater control. The setting that does this is known as the inspiratory rise time. So here we are on a pressure limited breath. We're starting off at a PEEP of 5 and an airway pressure target of 20 centimeters of water. So the inspiratory pressure ramp is that 15 centimeters of water of driving pressure. And on control, it just flows down the pressure, the pressure gradient from high pressure to low pressure. But that, by putting a little clamp on the side of that, you can adjust or control that initial flow rate, and that's the rise time. This is a typical pressure support series of breaths. Note here that the ventilator cycles from PEEP to the peak airway pressure, or the plateau pressure, or the pressure support level. There's also a little divot before each breath. This is evidence of negative airway pressure that triggers the breath, although triggering is usually by flow by. The little divot is followed by that upstroke. So the breath is initiated with that divot, and the difference in pressure within the airway itself is the true pressure ramp. And so that's the difference between the depth of the divot and the pressure support level, and that may add 4 or 5 centimeters of water of driving pressure. And remember, that doesn't give you any kind of an idea what the transpulmonary pressure is. It just gives you the pressure ramp that we're looking at right there and then. But what you really need to know at this part of this tutorial is what happens from the point where there is zero flow in the system to peak flow. And that refers to the concept of rise time. Sometimes that flow starts off really fast, so you have a high rise time, or it starts really slow. There's a slow rise time. So that's what we're going to talk about, and it's the rise time, and it's on the flow waveform. You only see this in pressure limited modes of ventilation. These are pressure control, pressure assist control, volume control plus, or PRVC, or pressure support, or tube compensation, or volume support, proportional assist, bi-level. They're all pressure control modes, and all of them will have some form of rise time. Sometimes it's known as a slope. It has different names. So the rise time, I think, is the cutest name for it. It's the time it takes to achieve the inspiratory pressure limit. If the patient has high flow demands, then a shorter rise time will be more comfortable for the patient. However, this may lead to overshoot and more rapid cycling of the ventilator. On the other hand, too short a rise time increases inspiratory time and may increase the work of breathing. So you got to titrate it for the individual patient. There are different systems for rise time and different ventilators. I'm going to start off with the Puritan Bennett 980 ventilator and its rise time. Just to remind you, this is only in pressure limited modes. It's quite confusing on the Puritan Bennett ventilator because it uses a proprietary algorithm in pressure support that's very hard to get your head around. So I'm just going to keep it simple. On the Puritan Bennett ventilators, the rise time is set in percentages, and that is the time it takes to reach 95% of target pressure. It varies from 1% to 100%. The higher the rise time in percent, for example, 75% versus 50%, the more rapidly the airway pressure reaches its target. So 75% is quicker than 50% for reaching the target. A setting of 50% takes half the length of time to reach the target than a setting of 100%. So the higher the rise time, the quicker the breath is, being from when the ventilator releases gas to where the target pressure is arrived at. It's not instantaneous. It is the proportion of time it takes to reach 95% of the target pressure. The higher the number, the shorter the time to reach the target. Let's look at a few examples of rise times. If you look at the bottom right hand side of the screen, you'll observe that the rise time has been set for a modest 30%. That means the breath will slowly rise to the target pressure. You will notice that the pressure ramp here is 15 centimeters of water plus the negative pressure generated on inspiration. Remember, in pressure support, the pressure ramp is always greater than the delta pressure, that is the pressure support minus the PEEP. Also keep in mind the expiratory sensitivity. That's the top right hand corner of the screen. This is set at 25%, meaning that the ventilator will cycle to expiration at 25% of peak flow. Now, in the subsequent examples, I am not going to change the expiratory sensitivity. That's for the next part of this tutorial. But just keep in mind that the time it cycles from inspiration to expiration changes from breath to breath, regardless of what the expiratory sensitivity is. So this is slow rise time. The Servo and the Draeger ventilators have a more intuitive approach to rise time. You set the rise time in seconds or fractions of seconds. The usual rise time would be between 0.15 to 0.2 seconds. That's equivalent to about 50% on the Puritan Bennett ventilator. Now, there are extremes. The extreme rise time on the Draeger vent is about 2 seconds. I don't know why you would ever do that. On the Servo vents, it's 0.4 seconds. That's the longest time between triggering and reaching the pressure support level. This is a screen capture from a Draeger ventilator of a patient breathing spontaneously. Here are the settings, and you can see here that there is a setting known as slope. And on this slope setting, you can see the number 0.2. And what that reading means is that the inspiratory rise time is 0.2 seconds. It's very, very straightforward. Let's look at a Servo screen capture. And on this, you can see here, there's the inspiratory rise time in seconds. So it's 0.15 seconds. That's the time from zero flow to reaching the pressure support level. Also worth noting on this is the trigger flow at 2. And just to remind you, when you set that at 2, it means that 80% of base flow needs to be deflected to trigger the vent. That's quite a significant trigger. So pretty tough on the patient. Here we are with an optimal rise time of 70% and a very nice flat top looking pressure support waveform. The pressure support here is 15 centimeters of water, and that's driving a tidal volume for this breath of 420 mils. There's our rise time there. This is the same patient, and have a look at the waveforms. What do you notice here? Well, the first thing that you notice is that the tidal volume has fallen to 350 mils, which is a fairly dramatic fall in tidal volume. And then you'll see that the pressure waveform is unusual. There's a spike. It's not flat, and instead of being a nice flat top, it's slanting downwards. And pay attention to the rise time. It's set at 80%. And this is just too fast for the patient. And the airway is overpressurizing, and the breath is cycling to expiration too quickly. So this is too fast a rise time for this patient. Well, what do you notice here? Hopefully at this stage of the course you will be familiar with scooping of the pressure waveform, which, as we have previously discussed, is caused by inadequate flow delivery to match patient demand. As a modern ventilator can deliver up to 200 litres of flow, it is likely that the problem here in pressure support is really sabotaged by the bedside clinician. And sure enough, the rise time has been set at 60%, resulting in inadequate flow and air hunger. In both of these scenarios, changing the rise time to 70% resolves the problem. So that's an idea of what to look for if you think there's a problem with that initial rise time in most patients. And if you just work a little bit further when you're looking at diseased lungs, in general, the standard rise time is 50%. If the lungs are highly compliant, you can give a much higher flow initially. If they're poorly compliant, for example, if a patient is recovering from ARDS, if that's fibroproliferative disease, if they have dense consolidation but they're oxygenating reasonably well, if they have pulmonary fibrosis, you might want to slow that down and give the gas flow a chance to get into the lungs so that it doesn't slam against the lungs and then cycle to expiration too quickly. So it's really important to try and sculpt a pressure waveform using the rise time. In the first example, the waveform just looks wrong, okay? And it's that horrible peak in the slope downwards. In the second example, you can see the M-shaped scooped pattern of inadequate flow. And in the third example, well, now we have a nice flat top pressure waveform. So sculpt away and try and get that nice rise time for your patient. Going back to this picture of slow rise time, you can see that a driving pressure of 20 centimeters of water only delivers a tidal volume of 350 mil. So these lungs are poorly compliant. As I've said, it may be fibroproliferation, it may be consolidation. Irrespective, the compliance is poor. In this case, the inflow, the rise time, and the outflow, the expiratory sensitivity, need to be adjusted to ensure the patient receives a reasonable tidal volume. Here is an example of a patient on pressure support ventilation. Note that the rise time here is 70%, and all the other pressure support parameters are fairly standard. There's the V-sense, this is the flow trigger of 3, the expiratory sensitivity of 25%, and you'll notice the patient's on a PEEP of 8. Let's move on to mid-range flow. Let's move on to a topic that you won't read about in textbooks, what I call the mid-range flow. This is a flow waveform for a patient on pressure support. Note that the patient's peak flow here is about 60 liters, just short of 60 liters per minute. And because the V-sense is set at 25%, the minimal flow here is roughly 15 liters. In between the peak flow and the minimum flow, there is another flow, and that's known as the mid-range flow. And that's where the flow is continuing to be delivered to the patient who may be continuing to inspire and maybe generate some fairly impressive transpulmonary pressures. And what you want to do is see that the flow is matching patient demand all the way along that breath, and that will be reflected in the pressure waveform. Theoretically, flow should be unlimited in pressure support ventilation. The stronger the patient's inspiratory effort, the greater the flow. However, older ventilators may be flow limited. In this scenario, the driving pressure is 15 centimeters of water above PEEP, and the rise time is set to 80%. There is a big inspiratory divot that almost reaches atmospheric pressure, followed by the inspiratory waveform. You will notice that we don't have that nice flat top pressure limited waveform that we are familiar with a droopy scooped out picture, eerily reminiscent of the one I showed you in the tutorial on volume assist control. And this is the same thing, it's demand flow Dyssynchrony. The tidal volume here is inadequate, and so is the ventilator. So this isn't a problem with rise time, this is a problem of the ventilator just not being able to reach the patient's flow demands. If you are sure that the patient cannot be extubated, they're certainly strong enough to be extubated. I can tell you this patient has phenomenal respiratory mechanics, but perhaps there are issues with level of consciousness or secretions, or perhaps there's a problem with CO2. There's all kinds of reasons why patients may have a strong respiratory drive, but you cannot extubate them. In that situation, if you're seeing this kind of a picture on the screen, you should seriously consider changing the ventilator to a newer model. Here I have swapped out the ventilator for a more modern machine capable of generating significantly higher flow. And you can see that the peak flow here is more than 80 liters per minute, with the ventilator cycling to expiration at around 23 liters per minute, delivering a tidal volume of 420 mils. Note that with the greater flow characteristics of this machine, the rise time can be reduced here to 70%. It may also be worth considering to change the trigger from flow to pressure given the patient's inspiratory strength. In this scenario, the patient has a tremendous inspiratory drive below atmospheric, and this results in a very, very large inspiratory ramp and a very high tidal volume. We don't know what the transpulmonary pressure is, but it may be substantial. In order to measure transpulmonary pressure, you need to place an esophageal balloon in the patient and connect it to a manometer. The technology is not used in most ICUs and requires a fair amount of skill and precision, and actually, once you've measured it, a plan about what you're going to do about it. It's easier to look at the flow demands on the flow waveform to really give you an idea of what the transpulmonary pressure might be or how strong the patient is. Normally in pressure support, the flow demand is 40 to 60 litres. Above this level, there should be some concern. In this picture, the patient's flow demand is 110 litres per minute. This is staggering but not uncommon. It may result in negative pressure-induced stretch injury to the lungs, and that may not be desirable. Consideration should be given to sedating the patient or looking at an alternative vent strategy. And we saw a lot of this in patients who were recovering from COVID-19, who are still quite hypoxic but breathing on their own and taking these massive tidal volumes with huge flow demand, even on minimal settings. And it really is hard to know what to do with this, but you really need to think about what you're doing regardless. This is a patient on pressure support. Observe the really nice flow waveforms here, the variable tidal volume and the beautifully square pressure waveforms. This is what you want to see, where the mid-range flow is really nice and it continues to be delivered to the patient. In this situation, the patient's only requiring about 35 litres of peak flow. Let's review this tutorial. In this tutorial, we looked at the start of the breath and the initial gas flow in all pressure-limited modes of ventilation. We looked at the inspiratory pressure, the transpulmonary pressure, and the slope of the inspiratory pressure curve. We introduced the inspiratory rise time and the settings that one puts into the ventilator. And then we saw how alterations in the rise time may result in patient ventilator dyssynchrony. Finally, I looked at mid-range flow and demand flow dyssynchrony. In the next tutorial, we will visit the main purpose of pressure support to match flow and demand with tidal volume. We will initially discuss the inspiratory pump, the transpulmonary pressure, and we'll see how it interacts with positive pressure to generate flow and subsequently tidal volume. We will then look at how pressure support is set and how to modify the settings based on the clinical condition. Well, I hope you found that tutorial useful. We'll be moving on next time to pressure support part 3, how we set the tidal volume. If you enjoyed this video, please give me some likes. Don't forget to subscribe to the channel so they keep on coming. And I'll see you next time. I guarantee you'll learn something.